Good evening, everyone. Myself, Dr. Aishwarya Kadam from Government Medical College, Nanded, Maharashtra. I'll be presenting on the topic primary angle closure disease with retinitis pigmentosa in 2 of the 4 siblings. Retinitis pigmentosa affects over 1 million people worldwide. It can be associated with other ocular conditions like cataract, glaucoma, maculopathy, etc. So we present a case series here which shows association between PACD and glaucoma and RP. So 2 siblings, a 39-year-old female and a 34-year-old male, presented to our OPD who were diagnosed case of retinitis pigmentosa, and they complained of diminution of vision since childhood and night blindness since childhood. They had a positive family history with their father having similar complaints. On examination, both the patients had vision of 6/60 and N8 in both the eyes. Both the patients had anterior chamber depth of Van Herrick's grade 1, and rest of the anterior segment findings were unremarkable with normal axial length on A-scan biometry and had minimal myopic refractive error. On gonioscopy, both the patients had more than 180-degree oppositional angle closure on indentation gonioscopy. The IOP was normal with less than 21 mm Hg in both the patients. On undilated fundus examination, a pale disc with 0.4 CDR with absent foveal reflex, attenuated blood vessels, and bony spicules were seen in both the patients. And both the patients were diagnosed with PACS with retinitis pigmentosa and underwent prophylactic NDR peripheral iridotomy in both the eyes. Subsequently, the younger 2 siblings of the patients also underwent ocular examination and had no evidence of retinitis pigmentosa or shallow AC. This is a fundus photo of left eye of the male patient showing retinitis pigmentosa, and the photo below is a slit lamp image showing Van Herrick's grade 1. This is the pedigree chart of the family in which the father is affected with retinitis pigmentosa with 50% of the offsprings suffering with the disease. So what is unique in my case? We are reporting cases of 2 of the 4 siblings who presented with shallow anterior chamber depth and retinitis pigmentosa. Association of retinitis pigmentosa with POAG is a known thing, but with PACD it is rare. A study conducted by Dr. Zia Pradhan et al. Concluded that 6% of the RP patients have PACD of some form, including PACS, that is 2.9%, PAC in 0.7%, and PACG in 2.3% of Indian population. A large population-based study from Taiwan concluded that RP group had 3.64 times higher risk of acute angle closure as compared to control group. RP patients are at a higher risk of developing PACG, and thus gonioscopy should be performed regularly to identify those at risk of PACG. Optic disc examination and perimetry on just these 2 examinations, it could be often difficult to differentiate damage caused to optic nerve by glaucoma versus that due to retinitis pigmentosa. Hence, IOP monitoring and gonioscopy play a key role to pick up such patients. Additionally, use of ASOCT and UBM can weigh in on diagnosing angle closure in such cases. Regular ophthalmic evaluation should not only focus on retinal health of RP patients, but also on other potential complications like glaucoma to allow early intervention and better outcomes. Gonioscopy should be part of routine examination for all RP patients to mitigate the risk of glaucoma-related vision loss, as it further compounds the visual impairment that is already present because of the RP. As RP patients often undergo repeated dilated fundus examination, gonioscopy prior to dilatation can prevent any risk of acute angle closure episode. Thank you.
So very well presented, and I got to learn something new, that there is an increased risk of angle closure glaucoma in RP.